Welcome to Learning Thursdays. I'm Dean Hale with the OASAS Learning and Development Unit and your host for today's presentation. Today's presentation is titled What to Know About Xylazine and Other Emerging Novel Psychoactive Substances in the Unregulated Drug Supply. And our presenter is Dr. Kelly Ramsey, Chief of Medical Services for New York State OASAS. She'll be joining us in just a moment. First, a word about Learning Thursdays. Learning Thursdays are offered to behavioral health professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce as we strive to improve the lives of individuals needing prevention, treatment, recovery, and harm reduction services. A goal of Learning Thursdays is to support the professional development of the treatment, prevention, and recovery workforce. We do this by offering regular presentations that are relevant to today's substance use disorder treatment professional. As always, if there are any questions, comments, or suggestions, please feel free to contact us at the Learning Thursdays mailbox. You can use the same mailbox to express an interest in providing a future Learning Thursdays program. And now it's time to start the presentation and welcome Dr. Ramsey.
Thanks so much, Dean, for having me. First, a couple of disclosures. I do not have any financial disclosures, but I will be discussing briefly off-label use of medications for the management of xylazine withdrawal and the treatment of xylazine use disorder. Our learning objectives for today: discuss what novel psychoactive substances, or NPS, are, discuss emerging NPS and drug trends in the United States. Then we'll take a deep dive into one specific NPS, xylazine, and very briefly discuss an overview of its history, its structure, pharmacology, clinical effects, emerging epidemiology, and ethnographic research, its contribution to overdoses, xylazine overdose prevention strategies, and harm reduction strategies for xylazine use, wounds due to xylazine use, xylazine withdrawal, and its management strategies, as well as treatment for xylazine use disorder. It will be a relatively short presentation on xylazine. If you're interested in a more in-depth presentation on xylazine, we have another Learning Thursday that's dedicated just to xylazine. And then I will briefly discuss toxicology testing and drug checking strategies for NPS. So first, this is a picture of worldwide substance use, and this comes from the United Nations World Drug Report from 2022. So again, looking at the different patterns of substance use around the world. So the greenish bluish color is representing use of cocaine. The purple color is representing use of opioids. The orange color is representing use of amphetamine type stimulants, or ATS, and the yellow is representing HIV among people who inject drugs. So you can see, depending on where you are geographically in the world, there is different substance use, again, depending on local availability and other variables, preferences, etc. But again, depending on depends on what you may be looking at for policy in your particular area of the world. As you can see in the United States, the biggest issue is with opioids, particularly opioid-related overdose deaths, but we're also seeing increased use of amphetamine-type stimulants, and then a smaller amount of cocaine or other stimulant use. So let's define what we're talking about. So designer substances, or new or novel psychoactive substances. So there are a couple of different definitions for NPS. They can be defined as individual drugs in pure form or in complex preparations that are not scheduled under either the Single Convention of Narcotic Drugs, which is from 1961, or the Convention on Psychotropic Substances from 1971. They may be categorized by their chemical structure, by their psychoactive properties, by biological targets, or by their source, whether they come from a plant or they're synthetic, or it's a combination of both plants and synthetic manufacture. The emergence of many, including hundreds of NPS in the past decade is challenging for obvious reasons, both for public health in trying to curb overdoses and other associated harms, and for drug policies globally. The designation new or novel does not necessarily indicate new chemical entities, but refers to compounds that have emerged recently in unregulated recreational drug markets. So this is the definition of NPS from the Center for Forensic Science Research and Education, or CFSRE. So their definition has been refined. The European Community definition of NPS as a natural synthetic or semi-synthetic substance in pure form, mixture or preparation that can be categorized using at least one of the following criteria, of which there are 5. A substance that has been discovered or synthesized for the first time since the mid-2000s and is being ingested regardless of degree of psychoactive effect. Some examples are listed there. A substance that was previously discovered, synthesized, or reported, for example, there are patents for it previously, or there is information about it in the literature already, but has been observed in the current recreational drug supply or identified in toxicological samples for the first time in more than 10 years. So a good example of that is Nitazine, which showed up again probably in the late 2010s, but had been discovered many decades ago. Number 3, a substance that since the mid-2000s has been used in a novel way or differing manner from its originally intended use. For example, in a different dosage form or amount to produce effects and has a different preparation. So some examples include fentanyl, which emerged in the unregulated drug supply in a powder formation. When it is utilized in a pharmaceutical manner, it comes in a patch formulation or a lollipop formulation, but does not come in a powder formulation. And some others listed there are loperamide and xylazine. Xylazine we'll get into more in a little bit, but that is converted from a liquid preparation that's used in veterinary medicine. It is crystallized and becomes a powder formulation that's added to the fentanyl drug supply. 4th, a substance that previously was not well described or studied, but now presents significant challenges or threats due to an altered toxicological effect profile as a result of increased use or popularity. So examples of this include kratom, or various isomers of THC, the main psychoactive component in cannabis. Lastly, a substance that is not controlled by the UN drug conventions, so the ones I've mentioned previously, the 1961 and 1971 conventions, but that may pose a public health threat comparable to that posed by substances listed in those conventions. An example of that would be quetiapine, whose name brand is Seroquel. So a little bit more detail about what novel psychoactive substances, or NPS, are. So they are often marketed as legal alternatives to more traditional substances of misuse. So here are some examples. They're created by chemists who take from biomedical and patent literature for quote unquote malicious purposes. They are available as standalone products, counterfeit medications, or illicit substance adulterants. They're easy to obtain from the web, the dark web, or street drug dealers. They're used without detection since urine toxicology tests usually do not identify these substances. The internet specifically has facilitated the widespread availability and misuse of NPS. Biomedical research has identified the molecular mechanisms of action for misused substances. Online databases describe recipes for making novel substances that target specific mechanisms. Marketing and sales of new synthetic substances on websites allow anonymous purchases, and transnational crime organizations from various parts of the world have joined those selling NPS on the internet. This also comes from the UN World Drug Report from 2022, and this is again looking at novel psychoactive substances from the perspective of demand, supply, and key issues. So a lot of information on this slide, so I'm not going to go into detail with each item, but I'll just highlight a couple of them. So for example, NPS were consumed in most countries in 2020. Use of NPS may be decreasing in North America and Europe, but Eastern Europe, Asia, and possibly Africa are likely experiencing midterm increases in use. That's from a demand perspective. From a supply perspective, the number of NPS on the market has stabilized. 548 NPS were reported in 2020, of which 77 were identified for the first time. Some potential key issues: opioid NPS, which include fentanyl analogs, continue to emerge. They represented the fastest growing group of NPS identified for the first time at the global level in 2020 and constitute the most harmful group of NPS due to the potential for fatal overdose. This is from that same report, but specifically drilling down to the Americas in looking at demand, supply, and key issues. Again, I'll just point out a couple of key points here. From the demand perspective, in North America, cannabis products with high THC contents are proliferating. Average THC levels continue to increase while levels of CBD, which is the non-psychoactive component of cannabis, are falling. From a supply perspective, interceptions of cannabis are declining substantially in North America despite a rapidly growing cannabis market, as cannabis interdiction has become less of a priority. And then some key issues. The opioid epidemic related to illicitly produced fentanyls in North America has been driving the number of overdose deaths to record highs, and with an acceleration during the COVID-19 pandemic. So progression of NPS over time. This is a timeline from 2008 to 2021. So very interesting to see the progression of NPS over time. So starting in 2008, we had the first generation of synthetic cannabinoids and cathinones. In 2010 to 2012, we had the second and third generation of synthetic cannabinoids. And we saw another group of NPS called pyrovalerones emerge. 2013 to 2014, we saw third and fourth generation synthetic cannabinoids and the emergence of acetylfentanyl, one of the fentanyl analogs. In 2015, we saw fifth generation synthetic cannabinoids and designer benzodiazepines emerged, as well as other novel high potency synthetic opioids. In 2016, we saw additional fentanyl analogs, more novel other high potency synthetic opioids, and more designer benzodiazepines. Between 2017 and 2018, we saw the rise of additional opioids and benzodiazepines, more synthetic cannabinoids, and additional cathinones. In 2019, we saw an ongoing expansion of designer benzodiazepines, a shift to non-fentanyl opioids, and in 2021, additional benzodiazepine and non-fentanyl opioid proliferation. So you can see it's a very dynamic progression over time. As far as NPS classifications, there are a number of classes. There are synthetic opioids, which act as agonists at the mu opioid receptors. In other words, they activate those receptors. And some examples of those are fentanyl analogs and the Nitazine analogs. There are synthetic stimulants, which alter the function of the dopamine transporter. Some examples of those are trimethoxyamphetamine, cathinones, or bath salts. Synthetic cannabinoids, which act as agonists, again, activate the CB1 receptors in the brain. And I've listed several examples there, including a chemical formulation, as well as some of the more familiar commercial names, such as K2 and Spice. Synthetic benzodiazepines, which modulate the function at the GABA A receptors. An example is etizolam. Synthetic hallucinogens, which can act at the NMDA receptors as an antagonist. So it blocks the receptor. So it works with a similar mechanism of action to ketamine or PCP. And an example of that is fluoroxetamine. Other synthetic NPS include xylazine, which does not fit into any of the above classes, and this acts as an agonist at the central alpha-2 receptor. Let's take a peek at the current US unregulated drug environment. So the unregulated or recreational drug supply in the United States remains dynamic, volatile, and increasingly toxic. Illicitly manufactured fentanyl and its analogs are the primary driver of drug-related deaths in the US, but they are not the only cause of deaths. So when we think about the unregulated drug supply, there's an acronym that we can use, MACD, which stands for misrepresentation, adulteration, cutting, and dilution of substance materials. So why does this occur? We don't know for sure. We definitely have a dearth of ethnographic data with individuals who are supplying substances to know why these mechanisms occur. However, we think it's to increase profits, to produce better effects of euphoria from the substances people are using, or to reduce potential unwanted side effects. NPS continue to appear in drug-related deaths. So let's look at cutting agents. So cutting agents are inert fillers that are added to a substance to add bulk to that substance. They make the substance easier to measure, distribute, and use. They add uncertainty as to the actual dose of the substance being ingested. Some common examples of cutting agents include mannitol, sorbitol, galactose, dextrose, microcrystalline cellulose, starch, corn flour, powdered milk, and dimethyl sulfate. There are also adulterants. Adulterants are pharmacologically active, non-scheduled substances added to a substance to add bulk or for other effects that they may cause that individual to experience. They increase the risk of adverse side effects and substance-substance interactions. Some examples of adulterants include acetaminophen, quinine, caffeine, theophylline, benzocaine, lidocaine, guaifenesin, dextromethorphan, phenacetin, metimazole, quetiapine, aminopyrine, tramadol, diphenhydramine, levamisole, diltiazem, hydroxyzine, phenylbutazone, acepromazine, and xylazine, etc. Let's just look at one example of an adulterant. So this is diphenhydramine, which is commonly added in the unregulated drug supply. So diphenhydramine is the generic name for the over-the-counter medication Benadryl. So the structure is pictured there, and here are some recommendations for clinicians with respect to diphenhydramine. So we as clinicians should be aware that substances may contain diphenhydramine, which can complicate that individual's clinical presentation. We should be familiar with the signs and symptoms associated with diphenhydramine toxicity and be aware that diphenhydramine can cause false positives on drug screens. Those false positives include for morphine, which would be an opiate on a urine toxicology test, for methadone, for PCP, and fentanyl urine dipsticks at high concentrations. So again, we need to be, when we're doing toxicology testing, we need to be aware of false negatives and false positives, and any point of care test always has to be confirmed with confirmatory testing, which is sent out to a lab. What are some frequent indicators of toxicity and anticholinergic syndrome that you can see with toxicity due to diphenhydramine? Delirium, agitation, restlessness, hallucinations, ataxia, tremor, seizure, flushed skin, elevated body temperature, mydriasis, blurry vision, urinary retention, and tachycardia. So one could consider, certainly for medical examiners and coroners, adding diphenhydramine to toxicology testing for overdose or suspected overdose deaths. And so it is a consideration for labs to include diphenhydramine on toxicology testing, and also to have confirmatory testing available for that. So looking at the bottom image, it's showing the frequency of diphenhydramine being detected with other substances identified in seized substances. So in West Virginia, 23% of the fentanyl samples also had diphenhydramine, and 23% of the cocaine samples also had diphenhydramine. So that frequency that you see diphenhydramine obviously varies geographically. So by this chart, you can see that the lowest, it showed up in 6% of cocaine samples from Illinois, and the highest was it showed up in 90% of opioid samples from Cook County, where Chicago is located in Illinois. So what is NPS discovery? So there is a drug early warning system, or DEWS, that helps us to identify NPS. So where do they get that information from? They get it from postmortem toxicology testing, from impaired driving testing, from emergency department information, from drug materials, from drug use forums, from gray or dark market sites, and from additional populations. And then what do they do with that information? That information is designed to improve monitoring, improve response, improve communication, and to give us information about risks. So again, we can do appropriate harm reduction, education, and information with individuals who are using substances. There are testing challenges with respect to NPS. There is a time delay between an NPS appearance on the drug market and availability to test for it. Why is that? It's because it requires availability of a reference standard. It requires development of an extraction and requires a validation of screening and confirmation analysis in order to have an effective test. There's an increase of scopes that requires careful balance of extraction and identification of different chemical classes. So this is true particularly with synthetic cannabinoids, which we'll talk about in a little bit. The whole process is costly and requires many resources, including development and validation of screening and confirmation methods, as I mentioned. Investigation will help narrow down the field of possibilities, and chemical testing suggested if products are seized. And then how do you determine whether you need quantitative testing? How much is it present versus qualitative testing? Yes or no? And then how do you interpret that testing? We're going to look at some NPS discovery trend reports. So this is looking at data from 2022. So since 2018, NPS discovery has reported 137 newly discovered NPS in the United States. That's in the figure on the left-hand side. And NPS opioids remain the largest subclass, and that's in figure 2. In 2022, NPS discovery reported the discovery of 21 NPS for the first time. So looking at the graphic on the left-hand side, stimulants are represented in green, opioids in blue, lighter blue, miscellaneous in yellow, hallucinogens in gray, cannabinoids in orange, and benzodiazepines in blue. So you can see a little bit of that variability over time. On the right-hand side is showing the number of NPS in those individual classes. So you can see opioids remained the most frequent NPS as far as the number of different substances, followed by cannabinoids. On this figure on the left-hand side, it's showing the breakdown of subclass of individual NPS detected. So this particular graphic is looking at 218 NPS were discovered in forensic samples. That's represented in the figure on the left-hand side. NPS opioids, stimulants, and cannabinoids represent the largest subclasses observed, and in 2022, 76 total NPS were detected. So looking at that breakdown by subclass, again, on the left-hand side, cannabinoids remained the most common, followed by stimulants, and followed by opioids. On the right-hand side is looking at NPS detected by year, cumulative since 2018. So you can see in 2022 alone, there were 76 new substances. The year prior, 2021, there were 101 new substances detected for the first time. In 2022, they observed that more than 2,200 total NPS detections within examined sample populations. So that's on the left-hand side. And that is breaking it up by year as well as by substance. So you can see that benzodiazepines are really appearing to have many more total detections than other substances. And a portion of more than 10,000 total NPS detections since their program was launched in 2018. So on the right-hand side, you can see that progression over time in each of the different classes. This is looking at NPS positivity in Q1 2018 through Q1 of 2023. On the left-hand side is showing benzodiazepine positivity, and Nitazine is the most common benzodiazepine seen over this time period. On the right-hand side is looking at opioid positivity, and there are a number of opioids that have been seen over this time, but carfentanil seems to be the opioid that is most observed. This is looking on the left-hand side at new generations of opioid positivity, and this is where we see other non-fentanyl opioids emerging, such as from the Nitazine family and others like Brorphine. On the right-hand side is showing fentanyl and fluorofentanyl positivity, and you can see that progression over time. On the left-hand side is looking at stimulant and hallucinogen positivity. And in this particular graphic, methadone is the most commonly found substance. And on the right-hand side, looking at synthetic cannabinoid positivity, there is some variability, but it looks like the MDMB4EN Pinaca seems to lead as far as the substance most frequently found. This is looking at drug and adulterant positivity, same time period. This is Q1 2018 through Q1 of 2023. The first upper left graphic is looking at the combination of xylazine and fentanyl. So there's a strong ecological link between xylazine and fentanyl. We see xylazine appearing almost exclusively added to the fentanyl supply, but not really to other substances. On the right-hand side is the link between quinine and heroin. On the bottom left is the link between cocaine, lidocaine, and levimisol. And on the right-hand side on the bottom, the link between methamphetamine and quetiapine. We're also seeing the rise of what's labeled benzodope, so a mix of designer benzodiazepines with opioids, a variety of high-potency synthetic opioids. Looking at the same time period, and again, we're just seeing increasingly a combination of those two substances together. On the right-hand side is again looking at that combination of fentanyl with a variety of other substances. So on the left-hand side is looking at fentanyl and Nitazine, again, a benzodiazepine that is synthetic. And on the right-hand side is looking at bromazolam and fentanyl. Now we're going to dive a little bit deeper into each of the different classes of NPS. So first, we're going to look at synthetic opioids or high-potency synthetic opioids. So here are a variety of structures chemically of different highly potent synthetic opioids. So on the left-hand side, you see diacetylmorphine. So that is the active ingredient of heroin on the upper left-hand side. And then below that is acetylfentanyl, which is a synthetic opioid. And so you can see how they're structurally quite different. In the middle, we see fentanyl, and then surrounding fentanyl are a variety of fentanyl analogs. So again, these are all synthetic opioids. So what are the effects of synthetic opioids? So they mimic the effects of heroin, but are much stronger. What are the methods of use for synthetic opioids? They can be injected, sniffed, taken orally, smoked, vaped, or inserted rectally, among other modes of use. What are the psychoactive effects? Euphoria and pain relief, but it can be much more potent than heroin. What are some of the adverse effects? Tolerance, physiological dependence, opioid use disorder, coma, respiratory depression, non-fatal and fatal overdose. How about specifically illicitly manufactured fentanyl and its analogs? Again, on the right-hand side are some chemical structures. So these are showing the high-potency synthetic opioids such as fentanyl, acetylfentanyl, butyrophentanyl, and then others such as U47700, MT45, and W18. You can see that they're very different structurally from the natural opiates such as morphine and heroin. Again, these all act as full agonists at the mu opioid receptors in the brain, so they fully activate those receptors. So fentanyl is the most prominent synthetic opioid in the unregulated drug supply in the United States. It is a mu opioid receptor agonist that is approximately anywhere from 50 to 100 times more potent than morphine. Fentanyl is found as a standalone product, a heroin adulterant, in counterfeit pills, and added to some other substances, cocaine and methamphetamine, for example, but it is not added to the cannabis supply. Fentanyl in the unregulated drug supply is manufactured outside the US, most typically, and trafficked into the US like other NPS. And fentanyl overdose deaths dominate overdose deaths in the United States. This is looking at NPS identified synthetic opioids from Q4 of 2022. So you can see on the left-hand side that the most commonly identified synthetic opioid from toxicology testing was fluorofentanyl. So here's the breakdown of what was found in this particular report. Fentanyl was identified in 258 submissions. Fluorofentanyl was identified in 97 samples. Isotonitazine in 3, metonitidazine in 3, 2-methyl-AP237 in 1, 3,4-difluoro-U47700 in 1, dipionone in 1, edodesnitazine in 1, and desethyl isotonitazine in 1, and protonitazine in 1. So clearly you can see that fluorofentanyl was the most common of those high potency synthetic opioids that was identified. What are the two benzimidazoles or nitazine analogs? So these are compounds that were developed in the 1950s by Ciba Pharmaceuticals, but they were never brought to market due to respiratory depression as a side effect. They are identified as having good analgesic action, so pain relief action, as well as muscle relaxant properties. They are especially effective, up to 60 times more potent than morphine. They've had a sporadic esoteric appearance throughout the last 7 decades. Etonitazine appeared in 2003, isotonitazine in 2019 in the US. It is most prevalent in Estonia, Germany, Latvia, Sweden, the UK, and has been associated with more than 250 deaths. Butonitazine was first reported in Ohio in 2021. They are commonly found in combination with illicitly manufactured fentanyl and its analogs, but also found commonly with designer benzodiazepines such as fluoprazolam, etizolam, and bromazolam. On the right-hand side is showing the names of some of the common nitazine analogs, as well as sort of a generic structural picture, and then showing some of the different chemical structure. So a little bit more about the nitazine analogs. Let's talk about the pharmacology. They are opioid agonists. They are structurally unrelated to any other opioid. They are lipophilic, which that has in common with fentanyl and fentanyl analogs. In other words, it's widely dispersed in the fat tissue of the body. And even though the action is relatively quick, the duration in which it remains in the body is relatively long. Naloxone does antagonize nitazine analogs. So again, naloxone is effective against all opioids, including high potency synthetic opioids. It can have an associated wooden chest syndrome, which means that the chest in a situation where people use nitazines or in an overdose situation have a very solid feeling chest after use. So this has been reported in preclinical studies when it was being investigated initially as a potential medication. And this is similar to fentanyl and its analogs. Nitazine and Clonidine were studied at the Lexington Narcotic Farm and found to be very euphorogenic with a severe opioid withdrawal syndrome associated with them. In the US, Nitazine and Clonidine were proclaimed by then President Dwight Eisenhower to be opiates and regulated accordingly beginning in August of 1960. What about the use of nitazine analogs? They are a white or beige powder or pills, often sold as oxycodone or hydromorphone, but these are far more potent than either oxycodone or hydromorphone. Routes of administration include intranasal use, which can be irritating due to the nitazine's acidity. They can be injected, they can be taken sublingually, they can be smoked, they can be vaped. Use is generally unintentional. Most often they are combined with fentanyl and its analogs and or with synthetic benzodiazepines such as Xylazine. Street names are isotony, and it's known for its potency like fentanyl, but duration of heroin. It's exhilarating and analgesic substance and helps induce sleep and sociability. Those are from qualitative interviews with people who use nitazines. What about detecting nitazines? There is no screening immunoassay. They are not detected like any other opioid. It requires specialized GCMS toxicology testing, which is a send-out test. And in the UK, nitazine analogs have been found as an adulterant in 25% of cocaine samples. A little bit more about the nitazine analogs. On the left-hand side comes from Reddit. This is a place where substances, particularly NPS, are often mentioned online. So this is the frequency in which it was mentioned online between January of 2020 and October of 2022 on Reddit. And this was specifically metonitazine, which is a drug derivative of etonitazine. On the right-hand side is looking at data from January of 2020 to January of 2022, and it's looking at detection of nitazines by month. This data comes out of Canada, and so you can see that precipitous increase over time, particularly between May of 2021 and January of 2022, and also the proliferation of different nitazines during that time period. This is looking at a geographical distribution of nitazine analog heat maps in the United States. So on the top left is looking at a heat map of isotonitazine. So you can see it's primarily focused in Wisconsin and Illinois. Next, on the upper right, we can see the heat map for Brorphine. You can see it has a similar distribution to where we're seeing isotonitazine. On the bottom left is the heat map for metonitazine. Again, pretty similar distribution. So we're seeing a pretty significant concentration there in the Midwest. And then in contrast, on the bottom right, we have the N-pyrrolidino etonitazine heat map, and you can see that there's more of a concentration that's spread out, but most notably it is in Florida and Appalachia. Next, a high-potency synthetic opioid we're going to look at is Brorphine. So what is Brorphine? So it is a substitute piperidine benzamidazoline. That's a mouthful. Sorry about that. It was studied in the 1960s, similar to the nitazines, as a potential opioid analgesic or pain medication. It has an efficacy and potency that is like fentanyl. In the US, Brorphine was first identified in the illicit opioid market in mid-2019. It can be used intranasally, it can be injected, it can be used by mouth. It is known on the street as purple heroin. There's a picture of it up in the upper left-hand corner of this slide. It's usually combined with other opioids and synthetic benzodiazepines and has similar potential side effects of opioid withdrawal syndromes and opioid overdoses, similar to other opioids. So on the left-hand side is showing the structural differences between fentanyl on the left Brorphine in the middle and isotretinoin on the right-hand side. On the right-hand side at the top is showing doses of Brorphine that are suggested in internet forums. So this actually tells you if you are an average beginner person using Brorphine versus a veteran, and then tells you for oral and smoking routes, how to use in a light dose, a medium dose, or a strong or dangerous dose. So again, this information is freely available on the internet. So what are the impacts on both the emergency department and the hospital setting by having such highly potent synthetic opioids in the unregulated drug market? So we're seeing increasing polysubstance overdoses and polysubstance use disorders. We're seeing longer lengths of stay, more patients requiring ICU care, more need to do non-traditional buprenorphine initiations, more withdrawal syndromes needing management, more need to manage withdrawal from synthetic benzodiazepines and other sedatives. We're seeing opioid withdrawal syndrome that is complicated by other withdrawal syndromes and use disorders, for example, to other substances such as xylazine, benzodiazepines, gabapentinoids, and alcohol. We're seeing more serious injection-related infections and more need for acute withdrawal management beds and expertise and hospital-based withdrawal management because of the increase in the number and the complexity of the cases. And the role of highly potent synthetic opioids in overdose death fatalities is difficult to determine because medical examiners often do not test for many of the different high potency synthetic opioids unless there is a specific reason to do so. Toxicology screens, for example, immunoassays for heroin and its metabolites do not detect high potency synthetic opioids. Fentanyl can be detected with a separate immunoassay, but fentanyl analogs cross-react with the antibody and may or may not appear. Studies which examine the presence of high-potency synthetic opioids showed that approximately 20% of fentanyl-related deaths actually were due to fentanyl analogs. Moving on to the class called synthetic stimulants. So what are some of the effects of synthetic stimulants? These mimic the effects of cocaine, but are often much stronger. Methods of use include oral ingestion, sniffing, injection use. Psychoactive effects include euphoria and increased energy like cocaine, but again, can be much more potent than cocaine. What are some potential adverse consequences or what is termed overamping? Increased heart rate, increased blood pressure and hyperthermia or elevated body temperature. Also agitation, delirium, psychosis, and death. Of the chemical structures that are shown on this slide, on the top left is showing the chemical structure of cocaine, which is considered a classic stimulant. Below that is the picture of MDPV, which is a synthetic stimulant. So again, you can see the difference in those structures. And then in the middle are showing some NDPV analogs from seized samples, again, showing their slightly different structures. What about synthetic stimulants and gunshot wounds? So this was an interesting article. It was an 18 case series study from Florida, and it was looking at the impact of synthetic stimulants on particular types of violence, and most specifically looking at homicide by gunshot wounds. So again, this is a small case study, again, only 18 cases from Florida, but it showed that the individuals who had the mode of death by homicide with gunshot wounds, and it showed the toxicology findings in those individuals. And you can see that the commonality in all the individuals in this case study was having a synthetic stimulant on board. What about synthetic stimulants and synthetic opioids? So there's an increased risk for overdose fatality when used in combination. So there's unintentional co-use. So this means contamination of the unregulated drug supply versus adulterated. So fentanyl adulterated or substituted heroin, levimisole in cocaine, or diphenhydramine in heroin. So people who use drugs are unaware that these substances have been added to the substance that they intended to use until after they use it. Then there is intentional co-use. So polysubstance use has always been the norm, and we're in a historic era of polysubstance use and increased consequences. So given our increasingly more fluid, unpredictable, and potentially dangerous drug supply, people who use drugs are making choices about what they use. And again, this is where drug checking can be very helpful in helping people make informed choices. Next class is synthetic cannabinoids. So synthetic cannabinoids mimic the effects of cannabis or THC, but are more pronounced. The methods of use include inhalation of smoke using bongs, pipes, or joints, e-cigarette vaping of liquid. The psychoactive effects include positive mood and euphoria, perceptual distortions similar to the effects of cannabis or with THC, and can be much more potent than cannabis. Adverse effects include increased heart rate, vomiting, kidney injury, hallucinations, psychosis, coma, and death. The chemical structures that are pictured on this slide up on the top left shows the structure of standard cannabis, natural cannabis with THC as the main ingredient, and then the other images show the chemical structures of some of the synthetic cannabinoids. So synthetic cannabinoids are causing localized epidemics with toxic exposures. There was an outbreak of intoxications that occurred in Illinois. There were hundreds of cases. Symptoms included severe bleeding with several deaths. Products also contain brorphine, which is a potent anticoagulant, so it caused people to bleed. There was an outbreak of intoxications that occurred in Connecticut. There were dozens of cases reported. Symptoms included hallucinations, catalepsy, so sort of a catatonia, and coma. The causative agent was indinazole, which is an indazole compound, FUB-AMB. Why are the effects of synthetic cannabinoids so much stronger than cannabis? Synthetic cannabinoids are more potent than THC because they exhibit a higher affinity than THC for the CB1 receptors. They are potent full agonists, so they fully activate the CB1 receptors, whereas THC is a weak partial agonist at the CB1 receptor. Synthetic cannabinoids generate bioactive metabolites, and these metabolites also are CB1 agonists. And synthetic cannabinoids may interact with non-CB1 receptor sites of action, such as 5-HT receptors, which are serotonin receptors in the brain. This is looking at synthetic cannabinoid fall-off between 2018 and 2022. So nearly all new synthetic cannabinoids fall outside the class-wide ban implemented in China, and the percent positivity has largely fallen off in the wake. So what is that saying? What it's saying is, as soon as we ban or classify a synthetic cannabinoid, the industry pivots and no longer makes that synthetic cannabinoid, but instead alters the structure slightly and makes a new synthetic cannabinoid that, again, we don't have a test to test for. Next, I'm going to discuss synthetic hallucinogens. So this is specifically about the substance 2CB. It's also known as 2C or tussie or pink cocaine, which is pictured over on the left-hand side. So this has experienced long-term growth in online discussions with a large uptick in mentions since late 2022. So what is 2CB? So according to the UN document on drugs, 2CB substances have been reported in Europe, Latin America, and North America in recent years, despite the drug's name and its similarity to the name 2 letters C-B. Analyzed 2CB samples often do not contain any 2CB, but rather ketamine. So these are often thought to be stimulants like cocaine, but they aren't. So they is often found in combination with ketamine or as pure ketamine, and then sometimes mixed in with other substances such as MDMA or Molly or ecstasy or cocaine or caffeine. On the left-hand side on the bottom is showing that trending of 2CB mentions on Reddit. So 2C, a new ketamine concoction complicating the drug landscape. So this comes from a publication that just came out in May of 2023. This again was looking at drug seizures of 2C, which again is ketamine, and showing you what it was found in combination with. So you can see most commonly it was found with a ketamine precursor, followed by MDMA or ecstasy, then caffeine, then methamphetamine, and then a variety of other substances in smaller amounts. This is a report from ND News looking at illicit ketamine seizures, which increased 349% in the US between 2017 and 2022. On the left-hand side is showing the number of seizures over time, and on the right-hand side, the weight of seizures over time. Next is synthetic benzodiazepines. So synthetic benzodiazepines act by enhancing GABA transmission in the central nervous system. GABA is the main inhibitory transmitter in the central nervous system. GABA A receptors inhibit cell activity, and benzodiazepines binding to the GABA A receptors enhance the effects of GABA. Synthetic benzodiazepines often are found within the context of polysubstance use. Adverse effects of benzodiazepines include drowsiness, dizziness, amnesia, and coma. Co-use of synthetic benzodiazepines and synthetic opioids is known as benzodope, which we discussed earlier in the presentation. Co-use of benzodiazepines and opioids exacerbates respiratory depression, and it does it by different mechanisms of action. Synthetic benzodiazepines increasingly are associated with overdose deaths. So this is looking at synthetic benzodiazepines in the US, Q3 of 2022. So you can see that the most common benzodiazepine detected per toxicology testing is Nitazine. In the middle, you can see the trending over time between Q3 of 2019 and Q3 of 2022. And you can see that Nitazine leads the frequency that which we see different designer benzodiazepines. All the way on the right, you can see NPS from Q3 of 2022, where benzodiazepines represented 50% of the NPS that were identified. Now we're going to take that quick deep dive into one specific NPS, which is Xylazine. Again, for more detailed information on Xylazine, I recommend checking out the Learning Thursday that is devoted solely to Xylazine. It's going to go pretty quickly through this section. So Xylazine is a non-opioid used as a sedative, anesthetic, muscle relaxant, and analgesic for animals. It was never approved for human use due to the side effect of severe central nervous system depression. It is approved in the United States by the FDA solely as a veterinary medication, and it's used for procedural sedation in large and small animals. When used in combination with opioids as a veterinary medication, it enables the use of lower doses of opioids and enhances both sedation and anesthesia. Xylazine does appear to be diverted from veterinary sources. It is not manufactured illicitly, and it seems to be diverted primarily from international sources of Xylazine manufacture. So we know a little bit about the history of Xylazine based on ethnographic research, primarily out of Puerto Rico and Philadelphia. So this is a data that was published in 2012. So the prevalence of Xylazine use in the previous 30 days in a study in Puerto Rico was 80.7%. And that was from people who use drugs that they recruited from a variety of communities in the San Juan metropolitan area. People who use Xylazine were more likely to be male, less than 30 years old, living in a rural area, and injecting versus inhaling Xylazine. Over 35% reported skin lesions, over 28% reported an increase in injection use, and over 21% reported at least one overdose episode. When they did this study in Puerto Rico using GCMS confirmatory technology, 90.6% of the syringes containing Xylazine also contained heroin or cocaine, and 22% of the syringes of participants who reported not using Xylazine actually contained Xylazine. So again, highly prevalent in Puerto Rico in the early 2000s. What is xylazine? It's a colorless liquid that's in veterinary formulations, pictured on the left-hand side in a DEA seizure, and the right-hand side, again, in its original packaging. It has to be converted to a bitter-tasting solid or salted crystalline substance that allows it to be dissolvable in water and then can be mixed with other substances. Some information about xylazine pharmacology and clinical effects. It is an alpha-2 adrenergic agonist, so it stimulates or activates the central alpha-2 receptors. And what the effect of that is that it decreases sympathetic nervous system outflow. So think of it as your fight, flight, or freeze response, and leads to sedation. So it decreases the release of norepinephrine and dopamine. This leads to profound central nervous system depression. It does not have a direct effect on the respiratory rate, unlike opioids, for instance, but the mechanism of action is as a muscle relaxant, it causes the tongue to relax. The tongue is a muscle, which physically blocks or obstructs the back of the throat, so prevents oxygen from being able to get to the respiratory system. So it's a more similar mechanism of action with respect to its effect on respiration to benzodiazepines and barbiturates. And there's a synergistic effect with opioids. So the major clinical effect is profound sedation. It in and of itself does not lead to hypotension and bradycardia, but it's often used in adults, but it's often used in combination with other substances that do lead to hypotension and bradycardia. The pharmacokinetics are that it has a quick time to effect, usually 1 to 2 minutes, depending on the administration route. It is lipophilic, as mentioned previously. It diffuses widely. It has good bioavailability. The average duration of substance effect is 4 hours, but it can last many more hours. So these are observations from the field. So these are anecdotal observations from people who use drugs about xylazine use and reported complications. So the first is that it can lead to overdose, heavy sedation, or a heavy nodding out. So this can be potentially dangerous for individuals who are using xylazine, whether knowingly or unknowingly, because they may be unconscious for a long period of time. That could make them vulnerable to things like sexual assault or physical violence, or being the victim of a robbery. It can also lead to medical complications if they are immobilized for many hours at a time. So including rhabdomyolysis, compartment syndrome, deep vein thrombosis or blood clots, skin breakdown, etc. It can lead to skin ulcers, which I'm going to talk about in a little bit. But again, we don't know the pathophysiology of these xylazine wounds. It's important to recognize them early so they don't progress into more complicated wounds. It can lead to hypoglycemia. So what happens when individuals use xylazine is it causes hyperglycemia or an elevated blood sugar, but immediately after use, then they can have episodes of hypoglycemia, which obviously could be dangerous for individuals, particularly with diabetes. There are also case reports of severe anemia in individuals using xylazine regularly. So the working hypothesis is that xylazine binds to hemoglobin in the bloodstream and decreases the efficiency of the distribution of oxygen. There is some veterinary literature in horses that does support the side effect of anemia after administration of xylazine. So this was a study that looked at xylazine experiences. This was a mixed method study of Reddit subscribers. So what were the results of this study? So people on Reddit describe xylazine as an unwanted adulterant in the opioid supply. Of those that disclosed their location, 50% of the participants reported locations in the northeastern United States. The most common route of xylazine use was intranasal use. 53% reported experiencing xylazine withdrawal, and there were frequent adverse events reported, including prolonged sedation in 81% of individuals and increased skin wounds in 43% of individuals. So we've been talking about the NPS throughout this discussion. So how does xylazine fit into that? So xylazine in the drug supply is following a multi-year progression of appearing increasingly in the unregulated drug supply. So as we've been talking about throughout this presentation, the number of NPS has increased over time and has completely replaced the historical heroin supply in many parts of the United States and Canada. So this just kind of shows that progression. So heroin itself became heroin and fentanyl, became heroin, fentanyl, and carfentanil and atizolam, then heroin, atizolam, any of the nitazines, plus fluoroprazolam and xylazine and brorphine and other high potency synthetic opioids. So what does all this mean? What this all means is a more confusing and potentially toxic unregulated drug supply. This is looking at the epidemiology of xylazine detections in drugs seized in Pennsylvania between 2010 and 2019. So you can see that that progression increased over time. So that was of xylazine being found in either fentanyl or heroin that was seized. This comes from a drug checking report from Q3 of 2022 from Philadelphia, when they tested samples in between May and September of 2022. They found that almost 100%, so 91% of dope samples, so that means either heroin or fentanyl samples, contain fentanyl and xylazine. So it has completely infiltrated the drug supply in Philadelphia. This is looking at findings in used syringes from a syringe exchange program. So over 350 syringes were collected in New York City and analyzed to see what was in them. So 77% were positive for one or more substances. The most common substance identified was heroin, followed by cocaine, followed by fentanyl, methamphetamine, furanyl fentanyl, and then a variety of additives or adulterants such as quinine, levimazole, caffeine, lidocaine, and phenacetin. At that time, during this study, and the study was published in July of 2020, what they found was that xylazine was present in 2.2% of those used syringes. This is xylazine detected by a drug checking in New York City. So in New York City in 2021, 19% of opioid-involved overdose deaths also involved xylazine. So in other words, xylazine was present in 19% of the opioid-involved overdose fatalities in New York City in 2021. This is looking at how prevalent is xylazine in the unregulated drug supply in the United States, because we don't have a good answer for that. This was an interesting study because it looked at a broad geography. So it looked at almost 60,000 samples from adults aged 20 to 73 years old in 39 states from around the United States. So what they found, and this was a primary care study, so this was not looking at syringe service programs or other locations. This was looking at urine toxicology in a primary care patient population. So in those almost 60,000 samples, they found xylazine in 413 samples and in 25 states of the 39 that they looked at. So this was published in January of 2023. Since that time, per the DEA, xylazine has been seized in 48 of 50 states in the United States. So this is a study looking at a pilot program to detect changes in the unregulated drug supply to tailor harm reduction responses. So this was looking at 8 syringe service programs in Maryland between November 21 and August of 2022. And what they found in these was, you can see on the left-hand side, all the way to the left, that is showing that ecological link between xylazine and fentanyl. And so you can see that xylazine's presence with fentanyl was far more common than any of the other substances' presence with fentanyl. This is data again out of Philadelphia, looking at the time period of 2010 to 2019, and this is looking at the number and percentage of heroin and or fentanyl unintentional overdose deaths that involved xylazine. So you can see it increased over time. So by 2019, xylazine was involved in 31% of the fatal heroin or fentanyl overdose deaths. This is data out of Philadelphia again between 2015 and 2020, looking at fentanyl co-detection among xylazine positive overdose deaths. So you can see by 2018 that xylazine was found in 100% of the fentanyl overdose deaths. This is looking at the presence of benzodiazepines compared to xylazine among all overdose deaths in Philadelphia between 2010 and 2020. So you can see that the presence of benzodiazepines was falling while the presence of xylazine was rising. This is looking at data out of Connecticut between 2019 and 2020, with xylazine emerging as a novel substance in overdose deaths in Connecticut. So what they found is that xylazine-associated deaths occur primarily among males and non-Hispanic white persons, and mortality was highest among persons that were young, aged 25 to 34 years old. 57% of the xylazine-associated deaths occurred at home, which was the most common location of overdose. The most common route of administration was injection, and toxicology results revealed that almost 86% of xylazine and fentanyl deaths included other substances such as cocaine, heroin, benzodiazepines, ethanol or alcohol, and gabapentin. This is coming from the CDC, from the Morbidity and Mortality Weekly Report. This was xylazine detection and involvement in drug overdose deaths in the United States as a whole in 2019. So xylazine was found to be involved in 1% of all overdose deaths in the United States in 2019, and it was listed as a cause of death in 64.3% of the deaths in which it was detected. So it's a bit challenging to interpret xylazine's role in deaths. So there's some reasons why. So we do not have any human pharmacokinetic or pharmacodynamic data available. So basically how xylazine interacts with the human body and how the body reacts to xylazine. So we don't know, for example, how much xylazine will actually affect an individual. We do know by animal data that a dose to sedate a 200-pound animal is about 50 milligrams of xylazine. So that amount would be associated with a plasma concentration between 68 plus or minus 15 nanograms per milliliter. When we look at xylazine in the unregulated drug supply per fentanyl glassines or wrappers that are currently being sold in the United States, about 30 milligrams total, about 3 milligrams of that is fentanyl, and about 31% or 9 milligrams is xylazine. There's almost complete overlap between driving under the influence deaths and death case considerations in fentanyl co-use cases. So the average concentration in fentanyl positive cases that have xylazine present is between 34 and 36 nanograms per milliliter. The literature values in deliberate xylazine ingestion suicides from living subjects are between 1,500 nanograms per milliliter and 4,600 nanograms per milliliter. So in other words, the amounts of xylazine that we're seeing in driving under the influence deaths, as well as overdose death concentrations, there's a wide variability, but often those levels are quite low. And as you can see, when people intentionally try to kill themselves with xylazine only, they survived relatively high levels. And so again, we're not exactly sure at what level xylazine has an impact on that individual's experience. So the conclusion was that xylazine contribution to the lethality of fentanyl is probably minor, in most cases at up to 30% purity as part of that drug sample, but it definitely contributes to sedation. And again, if that person is not breathing and has other substances on board that are also contributing to that challenge of breathing, that can contribute to a fatal overdose in that way. And also to the unique experience of the person using a longer period of sedation and potential other complications. So this comes from an ethnographic study published in 2022, looking at xylazine spreading across the US, a growing component of the increasingly synthetic and polysubstance overdose crisis. So from 2015 to 2020, the percentage of all drug overdose deaths involving xylazine increased from 2% to 26% in Pennsylvania. Xylazine was involved in 19% of all drug overdose deaths in Maryland in 2021 and 10% in Connecticut in 2020. This is from that same article. So this was a mixed method study, and it was looking to see how commonly we see xylazine across the United States. So most of our ethnographic data stateside comes out of Philadelphia. So this was trying to identify other jurisdictions which may be experiencing xylazine in the drug supply as well. So they looked at 10 jurisdictions representing all 4 census regions in the United States and found that xylazine was increasingly present in overdose deaths. So illicitly manufactured fentanyl was present in 98.4% of xylazine present overdose deaths, again, suggesting that very strong ecological link between fentanyl and xylazine. So what their conclusion was is that xylazine is increasingly present in overdose deaths, linked to the proliferation of illicitly manufactured fentanyls, and that it does have profound risks for people who use drugs. And many jurisdictions do not routinely test for xylazine, either via toxicology testing or via medical examiner testing in the case of overdose deaths. And we really have not been tracking it comprehensively nationally. That should change with the recent release of the ONDCP National Action Plan for xylazine. This is from that study as well. Again, you see xylazine and fentanyl are hand in hand, regardless of the jurisdiction that you're talking about. Here is showing Connecticut, Cook County, Illinois, Jefferson County, Alabama, and Philadelphia, Pennsylvania. But other substances may be mixed in as well, depending on your geography. This is looking at polysubstance overdose deaths in the fentanyl era. This is a latent class analysis published in 2022. This was very interesting. This was done out of 2 counties in Maryland, Baltimore City County and Baltimore County itself. So fentanyl was involved in 71% of all drug overdose deaths, and the majority, 76% of these deaths, included multiple substances. 3 latent classes emerged. Class number 1 was the fentanyl, heroin, cocaine class. That was 64%. Then there was a second class of fentanyl and alcohol in 18%, and a third class representing prescription drugs, including opioids, benzodiazepines, and antidepressants, which was found in 18%. And then they found significant differences between who used those classes of substances. So the fentanyl, heroin, cocaine class members were significantly younger, less than 30 years old, female and white compared to the fentanyl alcohol class, but more male and non-white than the prescription drug class. And all of those were statistically significant. So what does that mean? What that means is that our harm reduction education cannot be universal. It needs to be tailored to the population that we're working with, and we need to be familiar with the demographic and geographic differences in the patterns within the area that we are trying to do harm reduction education with. This data comes from a DEA report that was published in 2022. The report is called The Growing Threat of Xylazine and Its Mixture with Illicit Drugs. On the left-hand side is showing DEA forensic laboratory identifications of xylazine by region. It's a comparison between the years of 2020 and 2021 and showing the percent increase in that time period. So in the Northeast, that percent increase went up by 61%. In the South, it went up by 193%, the Midwest by 7%, and the West by 112%. On the right-hand side is showing the number of xylazine positive overdose deaths by region, again, comparing 2020 to 2021 and looking at that percent increase in that time period. So in the Northeast, the number of xylazine positive overdose deaths went up by 103% between 2020 and 21. In the South, it went up by 1,127%. In the Midwest by 516%, and in the West by 750%. In April of 2023, the Biden-Harris administration designated fentanyl combined with xylazine as an emerging threat to the United States. As I mentioned, they released a blueprint plan just last month in July of 2023. There was an article published in the New England Journal of Medicine in April of 2023, which is an excellent overview of xylazine, highlighting medical and public health perspectives. On the left-hand side is showing the estimated xylazine-involved drug poisoning deaths in the United States between 2018 and 2021. And on the right-hand side is showing an advanced xylazine-related wound if it is not recognized and treated early. What about xylazine overdoses? Are they similar to overdoses due to clonidine? So clonidine is an antihypertensive medication, currently FDA approved in the United States. It is a common source of both adult and pediatric overdoses. For adults, it's often in adults who have already a substance use disorder, and in children, it's often via accidental ingestion. So clonidine follows two different receptor pathways in the brain. There's the central alpha-2 receptor pathway and the imidazoline receptor pathway. So the central alpha-2 receptor pathway is responsible for the sedation, and that's where it's very similar with xylazine. But xylazine is not active on imidazoline receptors, and those receptors are what are responsible for bradycardia and hypotension. So that is why I mentioned that really if xylazine is used in isolation in adults, it usually does not cause hypotension and bradycardia. However, it can in children. And again, often people are using in combination with other substances that do cause hypotension and bradycardia. It's important to understand xylazine overdose intervention and management, but really this applies to any polysubstance overdose. So I already talked about the mechanism of action for the tongue blocking the airway and obstructing our ability to breathe with respect to the xylazine presentation. So what do we do for management in the field? So pre-arrival of emergency medical services, you want to give naloxone because again, xylazine is so often found in combination with opioid use. So we want to treat the opioid portion of the overdose with naloxone. We want to activate EMS, so call 911. Wait 2 full minutes before giving an additional dose of naloxone. And you want to then, if there's no response or not an expected response, and we aren't seeing normalization of breathing, we want to pivot, think polysubstance overdose, and then do airway maneuvers such as head tilt, chin lift, begin rescue breathing, and put that individual in the recovery position, which is pictured on the side. While you're waiting for EMS, if you have additional tools at your disposal, such as a pulse oximeter, you have a bag valve mask or ambu bags, you have the ability to administer oxygen, or you have oral and nasal airways available, which will move that tongue out of the way. You want to employ those additional tools or maneuvers until EMS is on site. There is no human medication or antidote for xylazine. So I do want to briefly address the myth of naloxone resistance. So as I mentioned, many, if not most, overdoses are polysubstance overdoses. Naloxone will only address the opioid component of the overdose. If there are other substances on board, such as xylazine, that do not respond to naloxone because they are not opioids, then if naloxone is the only tool in your toolbox, you're not going to have a successful reversal of that overdose. So as I said, you give 1 to 2 doses of naloxone, Then if there's no response, so no normalization of breathing, we're not seeking for an individual to be up, walking and talking, but normalizing breathing, then we have to pivot and think polysubstance overdose and do the maneuvers we discussed on the previous slide. So there is a very comprehensive document that came out from the University of Pennsylvania CAMP program, and it's looking at nascent xylazine best practices. So it talks about clinical effects and overdose management. So after xylazine administration, we talked about this, the onset of sedation is rapid and it compounds the sedative effects of fentanyl or any other high potency synthetic opioid that someone might be using, or a designer benzodiazepine, etc. So again, naloxone should be considered first line to try to normalize the respiratory rate. But then you want to pivot and do supportive care to try to increase breathing in that individual that we talked about already. And again, bradycardia and hypotension have been reported in intentional xylazine only overdoses, and these effects can occur from co-use with opioids. So sinus bradycardia, or a slowed heart rate, is most often asymptomatic, and mild hypotension or low blood pressure is often responsive to administration of fluids. So is the individual acutely intoxicated or high, or are they experiencing an overdose? You want to know the difference because you don't want to give naloxone unnecessarily. So what does acute intoxication or somebody being high look like? They usually have relaxed muscles, they have a normal skin tone, they may have slurred or slowed speech, they may have a drowsy appearance depending on what they're using in addition. They are responsive to stimuli, and they often have a normal heart rate, but again, that depends on what they're using specifically. What does an overdose look like? You would expect bluish color of the lips, skin, and nail beds, depending on the person's baseline skin tone. They would be unconscious, non-responsive to stimuli, possibly a slowed heart rate, again, depending on what they're using, and slowed or no respirations. So here's an example of how to give the rescue breaths: clear the airway, tilt the head back and lift the chin, pinch the nose and give 2 quick breaths, wait 5 seconds, then give 1 breath every 5 seconds. Don't give chest compressions unless the heart is stopped. So if they have no pulse, and they're not breathing, you do chest compressions. You treat to the level that you are capable of. So if you know and are trained to do full CPR, in that situation, you can do full CPR. If you don't know how to do CPR, then you can do the rescue breaths and activate EMS. This shows how to put somebody in the recovery position. So if a person has started breathing after you've administered naloxone or done some of these maneuvers, but they're not conscious yet, you want to put them in the recovery or rescue position. So in case they vomit, they don't aspirate the vomit into their lungs. Again, we talked about possibly using a pulse oximeter. This will indicate to you whether that person's oxygen level is low. So low would be less than 90%. So if it's less than 90% or decreasing, then you would want to intervene. At 70% on the pulse oximeter, the brain is no longer getting oxygen. Here are some details on what to anticipate in the context of a xylazine overdose. Some clinical findings include those on the left-hand side. We've talked about a lot of these already, so I'm not going to go through them in detail. On the right-hand side are some supportive care considerations. So again, we might need to give oxygen. We may need to give IV fluids. We may even need to intubate someone and have them get respirator or a ventilator support. We may want to monitor them with continuous monitoring with an ECG. We may want to monitor them continuously with a pulse oximeter. We may need to replace some electrolytes depending on how long they've been unconscious on the ground. Ongoing monitoring with prolonged sedation due to xylazine use or overdose is important. Individuals deeply sedated who cannot move themselves easily should be repositioned or moved every 2 hours. So you want to roll them to the opposite side, smooth out their skin, rub areas that appear red or swollen, keep skin as clean as possible, and flex or bend the joints. When that individual wakes up, you want to exercise the limbs to prevent blood clots. So even gentle walking will help. And then monitor for signs of a deep vein thrombosis or a blood clot. So redness, swelling, or pain in a lower extremity or foot, usually one limb only. What about diagnostic testing specifically for xylazine? So there are not commercially available point of care tests or for the hospital setting. There are not immunoassays yet. There are xylazine test strips, and they became commercially available in the United States about 3 months ago. And they have been validated, and so they do provide a qualitative answer, yes or no, whether xylazine is present in a drug sample. They are not yet FDA approved, so they would not be able to be used in urine samples without a full lab license. So if you're only approved with an LSL for a CLIA wave test, you cannot use xylazine test strips to test urine in clinical settings. Xylazine is eliminated from the body rapidly, so its half-life is only 23 to 50 minutes, so difficult to capture in a toxicology test. 70% is excreted in urine as its metabolite. So xylazine can be detected in both urine and serum or blood via more sophisticated analytical techniques, which take longer time to turn around. So this was looking at individuals who were using fentanyl or heroin that had xylazine in it and their willingness to use xylazine test strips. This was before xylazine test strips were available, and people said they were definitely interested in using xylazine test strips if and when they became available. And all of the individuals in this very small study did not appreciate xylazine being added to their fentanyl or heroin supply. In other words, they were not seeking it out. This is the validation testing for xylazine test strips. They proved to be very sensitive and specific. So out of 25 samples that were analyzed, 20 samples contained xylazine and the strips were able to detect it. 5 samples did not contain xylazine, and they were able to give a negative response correctly on the strips. This is additional validation testing that was done by BTNX regarding xylazine test strips. And what they found was that they were highly sensitive and highly specific and highly precise. However, lidocaine, which as we learned earlier in this presentation is often mixed in with cocaine, is an interferent with xylazine test strips and may lead to false positive test results in the field. We really will get more information over time from harm reduction programs and people who use drugs on practical tips on how to change dilution methods with different substances, particularly stimulants. This is looking at xylazine and skin ulcers or wounds. This is looking at the number of hospitalizations for skin and soft tissue infections associated with substance use between 2010 and 2019 in Philadelphia. And you can see that increase over time. So there's a lot that we don't know about xylazine, skin ulcers, or wounds. So these can develop into severe necrotic skin ulcerations that necessitate complicated wound care, but they don't need to get to that point if they're recognized early. They occur at skin sites associated with injection, but also at skin sites not associated with injection and in individuals who don't inject. Therefore, the pathophysiological mechanism which causes these ulcerations is unclear. They aren't infectious in and of themselves, but they can become superinfected with bacteria, particularly with skin picking. So there are some graphic photos on the next slide, so I'm just giving you a heads up. So on the bottom right-hand corner shows what an early onset xylazine wound can look like. So it's important to recognize wounds at that stage and do best practices in taking care of them so they don't progress into the other more complicated wounds pictured here, which require much more complex care to heal them. These are some tips on xylazine wound care. Important not to skin pick, Debriding of the wound, removing those dead areas, the black areas on the previous slide, may be necessary. It's important to keep the wound and the wound bed clean and moist. There's some suggested agents there. Really important not to use drying agents on it like hydrogen peroxide or alcohol, because that will cause the skin to break down more readily. Sometimes you do need to apply special ointments like antimicrobial ointment, etc., if it becomes secondarily infected. And it's important to cover it with an absorbent pad if it's weeping, and use a non-adherent dressing such as Zeroform. So here's what to do if the wound looks like it did in that bottom right-hand corner picture, when it's only a pinpoint wound. Always evaluate for infection and the need for systemic antibiotics. Is the person having fever, chills, fatigue, etc.? You want to be sure that they cleanse the wound. That can be with saline, soap and water, antimicrobial cleanser, and keep that skin dry. But if it's dry, you need to moisturize it. So around the wound, that could be with vitamin A and D ointment. And in the wound bed itself, you can use Vaseline. If you have access to medical grade honey, which is expensive, as needed with a topical antibiotic. And then you cover or wrap it. A primary dressing would be a bandage or a non-adherent bandage cut to size. And the secondary dressing would be rolling gauze lightly around it. If a wound has progressed to a more complex wound, again, evaluate for infection and need for systemic antibiotics. You cleanse in the same way. For moisturizing or medicating around the wound, again, you can use vitamin A and D ointment. In the wound bed, if there is dead tissue, it may require debridement, so removal of that dead tissue. You can use medical grade honey on the scab in the wound, and you can use antibiotic ointment on the tissue that is sloughing off or falling off. The cover, the primary dressing, would be a non-adherent porous matrix impregnated with Vaseline, so something like a Zeroform bandage, cut to side with an absorptive dressing as needed if there is discharge, and then it's wrapped with rolled gauze and tape, and then secured with a Coban wrap or Coflex wrap loosely. When do you need to triage individuals with a xylazine wound to a higher level of care? If they're failing oral antibiotics and or they have the wound plus what we call constitutional symptoms, fever, chills, malaise, or fatigue, or they're unable to get reliable outpatient or street-based wound care, or there's a lack of resources in general. What to tell patients? You want to advocate for patients if they do need to present at settings such as urgent care or the emergency department for pain management of their wound and for management of xylazine withdrawal. So if they're admitted to the hospital and using xylazine regularly with their fentanyl, you would anticipate that they're going to experience both xylazine withdrawal as well as opioid withdrawal. And you want to link them to professional teams to take care of them. This is an example if you're doing street-based wound care, some of the things that you can carry in your kit for that. Again, I'm not going to read through all of these, but it goes through each of the different items, what you use them for, and their prices on commercial websites. This is if you are doing wound care, but you had enough funding to have ideal supplies for taking care of xylazine wounds. Again, it goes through the items, the use of that item, and then the pricing on commercial websites. This is an example of a xylazine wound care handout for patients. So it goes through some of the wound care supplies, the self-care steps, where xylazine wounds often are found on the body, red flags to seek medical care, and then some helpful tips. This is another xylazine wound care guide that came out. It goes through very similar information that I've already covered, just presented in a little bit of a different way. And so again, I'm not going to go through that in detail. This is from the New York City Department of Health and Mental Hygiene, a wound care palm card. So it's a guide to wound care self-management for people who use drugs. On the left-hand side, caring for a wound, and on the right-hand side, when to seek medical care. Let's briefly go over xylazine withdrawal syndrome. It's not a well-characterized syndrome. The primary symptom is anxiety. It is generally not associated with severe vital sign abnormalities, and it's not associated with withdrawal seizures. The duration of symptoms is typically several days to several weeks, but it can last a lot longer than that. Currently, there are no evidence-based recommendations for the management of xylazine withdrawal syndrome. Having said that, there have been a couple of publications that have come out showing some nascent best practices on managing xylazine withdrawal. So for one, if you're treating somebody with opioid use disorder, particularly if they are in opioid withdrawal, ask them about their use. They may be aware if they're using xylazine or not, and anticipate xylazine withdrawal. So what the presentation may look like is that the initiation of medication for opioid use disorder, particularly with buprenorphine, may not go as smoothly as anticipated, or in using adjuvant medications to treat opioid withdrawal symptoms, you're not getting the expected relief for the individual that you had anticipated. So those are a couple of red flags to think about xylazine withdrawal. So there are no FDA-approved medications for the treatment of xylazine use disorder or the management of xylazine withdrawal, but there have been case reports showing benefit in the use of other alpha-2 agonists such as clonidine or tizanidine to help control withdrawal symptoms. And again, this might be seen in a variety of settings: inpatient hospital setting, admission for management of withdrawal symptoms setting. So again, everyone wants to be thinking about this and be on the lookout for it. This is a case report of a specific patient who had left care in the inpatient hospital setting multiple times because xylazine withdrawal was not being managed, and this person needed care for their xylazine wounds. The team on this particular admission heard her and treated the xylazine withdrawal appropriately. So they used a combination of medications. They used a dexmedetomidine infusion, phenobarbital, and tizanidine, and then they later were able to successfully transition her to clonidine. So by hospital day 4, she was no longer experiencing withdrawal symptoms. She was transitioned from full agonist opioids for pain to buprenorphine via a buprenorphine low-dose initiation strategy, and was ultimately discharged on buprenorphine, clonidine, and gabapentin on day 19 of admission. This is the document by Camp that came out with nascent best practices for management of xylazine withdrawal. I'm not going to go into the details here, but it goes into talking about co-presentation of xylazine and opioid withdrawal, the timing and the management of opioid and xylazine withdrawal, what severe symptoms may look like, and how to manage comorbid pain and opioid withdrawal management, and goes over some examples of strategies to consider for managing xylazine withdrawal. This is how to manage adjunctive treatment of restlessness and or agitation associated with xylazine withdrawal. And again, this makes some suggestions on different regimens of medications that you could consider using in that setting. So to wrap it up on xylazine, what are the big factors that are known with respect to xylazine? We know that it's being added intentionally to the unregulated drug supply. We think it is to increase the duration of fentanyl's effects, but we don't know a lot more than that. We know it's associated with skin ulcers and wounds. We know that it's found increasingly in the unregulated drug supply throughout the US, and we know that it leads to heavy sedation and overdose, and that it is under-recognized in most overdose situations. But there's so much we don't know. We do not know its actual prevalence in the unregulated drug supply outside of certain jurisdictions, and we've talked about the reasons why for that earlier in the presentation. We have comparative ethnographic experiences only really in Philadelphia and Puerto Rico, but not really anywhere else. We have information on a little bit on the concentration of xylazine and how it has affected experiences, but really we don't have definitive pharmacodynamic or pharmacokinetic information to know how an individual will experience xylazine and what actual impact on fatal overdose xylazine has and at what level or dose. We do not know the mechanism of action for skin ulcers or wounds or true best practices for wound care management. And again, we don't have best practices for the treatment of xylazine use disorder or xylazine withdrawal. And we don't know at what level xylazine gets added to the drug supply. So many have called for a safer drug supply. So what does that mean? So Canada is one country that is experimenting with having a limited safe supply program. So people who have failed treatment for opioid use disorder with the approved medications, methadone, buprenorphine, and naltrexone, that they are giving either injectable heroin or hydromorphone under controlled conditions, and they've had good social and health outcomes for individuals who failed treatment with other medications for the treatment of opioid use disorder. So a safe supply means that we would probably see fewer overdose deaths, and we wouldn't have as many unknown and unpredictable complications. So it could eliminate many of the issues related to an unregulated drug supply. However, this is very controversial in the United States. It is a mechanism that is utilized in Canada and parts of Europe, but it certainly hasn't yet come into common parlance in the United States. Another thing is that we can learn a lot about nuanced overdose response from how overdose prevention centers or overdose prevention sites worldwide are addressing overdose in their centers. So there's never been a fatal overdose at any overdose prevention site or overdose prevention center worldwide. And often they used a nuanced response with far less naloxone and more utilization of oxygen. So I think we have a lot to learn from looking at the lessons learned in these alternative settings. So the key to xylazine is awareness. So people who use drugs commonly report that their provider did not know anything about xylazine. They also, as we've talked about on previous slides, perceive that their xylazine withdrawal is not being recognized or treated, and this makes it more challenging for them to stay engaged in care. Negative patient experiences and previously poorly managed episodes of xylazine withdrawal lead to care avoidance, later presentations, more complicated care, and worse outcomes. And so when we're thinking about overdose presentations, again, think outside the box, think polysubstance overdose, and think about the different interventions we've already discussed. So xylazine conclusions, the prevalence is likely underreported, both in its geographic distribution and its contribution to overdose deaths. We've talked about all the limited research that we have on xylazine and some of the things that we still don't know, including a lot of best practices. We really need to start recognizing xylazine use and xylazine withdrawal, particularly in treatment settings. And we need to recognize that polysubstance overdose is the norm. And so again, the response shouldn't just be naloxone, but 2 doses of naloxone and then pivot and do other mechanisms to support breathing. I think importantly, we need to avoid drug panic. So we've spent almost 2 hours talking about NPS, but I don't think the solution is to get panicky about it. So when we see misinformation in the media or misinformation that is perpetuated by law enforcement, etc., what unfortunately that does is it increases stigma towards people using these substances, and it increases the likelihood that someone is going to hesitate before interacting or engaging with someone who might need assistance in an overdose situation. So here's a study on the left-hand side that was published in 2020. So they used a media cloud to compile and characterize mainstream and social media content published between January 2015 and September 2019 on overdose risk from casual fentanyl exposure. What they mean by that is that you can overdose if you touch fentanyl, or if you are in a room and you inhale fentanyl. Again, these are not exposures where somebody intentionally used fentanyl or even unintentionally used fentanyl, but it was ingested into their body. So despite the significant evidence we have that you cannot overdose by casual fentanyl exposure, either via touch, so via dermal exposure or via inhalational exposure, these myths are perpetuated in the media constantly. And we constantly hear stories from law enforcement and EMS, often the police, that an officer overdosed when they pulled somebody over who had fentanyl in their car. So these are not overdoses. I recommend you go to our fentanyl test strip guidance document, which has a section on myths related to fentanyl, and read through that. Those are panic attacks when people experience them due to their anxiety about having an overdose that way, but these are not factually based. So this study, again, they looked at relevant content that appeared in 551 news articles spanning 48 states. Misinformed media reports received approximately 450,000 Facebook shares, potentially reaching nearly 70 million users from 2015 to 2019. Amplified by erroneous government statements, misinformation received excess media visibility by a factor of 15 compared to corrective content, which garnered fewer than 30,000 shares with a potential reach of only 4.6 million Facebook users. So unfortunately, misinformation is proliferated at a greater degree than is factual information. And unfortunately, that is not benign. As I said, it contributes to worse stigma towards people who use drugs. And stigma is the greatest barrier to people who use drugs trying to access care, services, and supports. So what are some recommendations regarding recognizing NPS in your community? So overall recommendations regarding NPS are recognize that NPS trends are likely underreported. So again, we talked about differences in testing capabilities. Trends include those that are temporal and geographical in general. So they're time limited, and then also there are geographical implications. So a trend may not necessarily be specific to your geographical location, and often they're population-based. Think about the substance lifespan. So its appearance on the market does not necessarily correspond to popularity. Its lifespan is affected by legal status changes. So we talked about synthetic cannabinoids as an example of that. And there can be legal status changes both domestically and internationally. And recognize that substances in circulation change all the time. So street and product names like Molly and acid really mean very little. So just to wrap it up with some conclusions, the NPS market continues to evolve and the substance landscape continues to change rapidly. Biological effects of NPS resemble those of the substances they intend to mimic, but NPS are often much more potent. People who use drugs cannot be sure of the precise chemical constituents of the products they are using unless comprehensive drug checking exists in their community. NPS can be found as adulterants in illicit substances and in counterfeit medications. NPS polysubstance circumstances can be significant. We don't know the extent of the problem, incidence and prevalence, without comprehensive drug checking or testing. NPS are involved in and/or contribute to death. Overdose prevention and intervention education should include recognition of an appropriate response to polysubstance use and polysubstance overdose. Drug panic only exacerbates misinformation and stigma. Counter it with comprehensive solutions and an evidence-based narrative. So I put my email here in case you have any questions. It's kelly.ramsey@oasis.newyork.gov, and I'll turn this back over to Dean. Thanks for tuning in.
I want to thank Dr. Ramsey for today's program. I hope you all find it useful while assisting clients in need of our services. Your feedback is important to us. It helps us to know if we are meeting your educational goals and expectations. Once you have viewed this presentation in its entirety and completed the quiz, if prompted, please follow directions to access the SurveyMonkey website and take a moment to complete the evaluation. Once again, thank you for joining us and keep up the good work.